So yeah, my name's Michael. I'm an HIV physician. Is this work? Oh, it is working now. Thank you, Greg. I'm an HIV physician from London. I'm also the medical director of the Terence Higgins Trust, which is a large NGO in London. So I'm just going to talk or give you some of my thoughts, and they're including some reflections from the discussions that we've had today and yesterday about integrating PrEP into models of service delivery and what we have now, what the difficulties or the gaps are, and where it might go in the future. I think we'd probably all agree that we all have a very different range of service delivery models, but they're not maximal, they're probably very restrictive, and in certain cases they're actually a barrier to access to PrEP. And moving forward, I think we need to look at what we're beginning to learn, all the things that we've heard yesterday in terms of where we're all at with PrEP provision, to use that information and that knowledge to redefine and to evolve our service models to make them as accessible as possible to everyone, to ensure that they engage with all of those groups that we know we're not reaching at the moment. So that's really where I'm going with this talk, and as I said, particularly then thinking or giving some thoughts about what future models of care for PrEP might look like. I've developed this talk, there's lots of people who helped me with this, basically by just emailing out colleagues from Scotland, Wales and France to get their thoughts and feelings. So a lot of this has come from other people as well as some of my own personal experience. The clinic I work in London is in the area of the UK with the highest prevalence of HIV. We were a site for PROUD. We're currently a site for the impact study as well, so there's some personal experience. So I'll nip through some of this because we've talked about it yesterday, but just to make the point that we have a mixed bag of service provision in the UK, as previous speakers yesterday, Yusuf and George, pointed out. So we have impact in England with 10,000 places, nearly half full. We have kind of open access, if you like, NHS provision in Scotland. We didn't mention yesterday, although I was glad that Kate mentioned it today, there is PrEP available in Wales on the NHS in a much smaller programme, but you can get it there. And there's currently no PrEP programme in Northern Ireland. And as also we've heard from Danielle yesterday, PrEP's been available, well, it's into the second year now, the beginning of the third year in France. A model that, again, as the pros and cons were pointed out yesterday, is initially delivered through HIV clinics, although there is beginning to be a bit of rollout in sexual health clinics. Initially branded Truvada, and now generic provision, and as we heard, around 7,000 people accessing PrEP in France. Some other data which I got from French colleagues, this is from a report that takes us up until July of last year, looking at some of the characteristics of PrEP users in France. And I think this is the similar picture that we would all see when we look at the demographics of larger scale programs. This was when there were just over 5,000 PrEP users. Nearly exactly half of those were in Paris, so again, a very urban population. An older population, the mean age was 38, so perhaps not yet reaching younger groups. And I'm sure even though the data's not here, it would be the white, well-educated men who have sex with men. And we heard yesterday that I think less than 1% are women or from trans communities. So there's the challenge there that we need to make our service model acceptable to everybody. And the vast majority of people in France are still accessing PrEP through hospital services. I think when we start to think about what a service model should be like, we have to start with the individuals who we're trying to deliver the service to and for. So we need to go back to the communities that we are trying to support into engaging with PrEP programs. So this is just a scattered picture of many sort of campaigns, PrEP awareness campaigns that have been done in the UK, mostly by people who are sitting in this room. Oh, it's not, oh. Do you know what? I'm clicking on my thing and not clicking that, aren't I? There you go. And I've done all of these pretty pictures. How terrible. Do you know, I was thinking I was going to forget. It's like patting your head and rubbing your tummy. I was going to forget to integrate that with that. So yeah, I've told you all of these stuff. So just glance at the pretty pictures that I took ages showing you. There you go. So let me rush through. This is what's the most important slide that I'm going to show anyway. So a lot of the campaigns that have been led by community groups, individuals, as I said, many of whom are here in the room. And this has to be the foundation to the service model because, you could have told me sooner, the service models, we've got to raise the awareness and take it to the people who were trying to deliver the services. But no, I'm going to remember to do the clicker this time, don't worry. Right, just a final piece about engagement. And one of the commonest themes that came back when I spoke to people about, what has helped you to achieve what you have, whether it's Scotland, whether it's Wales, or whether it's France, was about third sector community organisation engagement that has driven the agenda, that has raised the profile in the media, that as NAT in England has driven the legal policy and political work, HIV Scotland. And I think we need to now move into the next phase of utilising that same sort of activist and community organisation power and passion and energy to inform the service models that we provide, because they will know best in terms of what they should look like. Nearly all PrEP provision, certainly in the UK, is currently coming out of sexual health services or being delivered out of sexual health services. That, in some ways, and this came from comments from colleagues in Scotland, has been a facilitator for PrEP rollouts. You know, there is an existing network of sexual health providers that PrEP has been dropped into. One of the other common themes that comes out when asking people about their experience is that there's been challenges in the capacity of services to deliver that work. And the more people who are put on PrEP, the more we realise that there are complexities, and that's a broad range of things. So complexities in terms of other need, mental health, drug and alcohol, chemsex, complexities in terms of maybe comorbidities. One comment from a colleague in Wales was they were surprised how many people have got renal problems, and that's been a problem with them getting into the trial. Different services are running different service models. So some clinics, certainly larger clinics, certainly in London, like Dean Street, have sort of skilled up most of their workforce. So PrEP is being offered in a sort of standard offer in their clinics. My clinic and many other services have done a sort of more specialised approach, so carved out specific PrEP clinics into which PrEP users or potential PrEP users are channeled. It's anecdotal, and we need to do the evaluation, but there's a sense that that's a more efficient way of doing it. I think one of the main challenges, we talk about cost as a barrier, and when we talk about cost, we're often thinking about cost of drug, but there is a real cost to service. PrEP users, by their very nature, are complex. They take a lot of time. You know, it may be either for reasons, you know, particularly new PrEP users, there's a lot of information to give, or because there's ahead of other issues like mental health, drug and alcohol, and so on. And there's a couple of people said the concept of the complex MSM consultation. I think it's actually the complex PrEP consultation, and that needs to be factored into funding and service delivery models to recognise the fact that these people need and take a lot of time. Some specific comments from French colleagues, as has already been mentioned. I think that there's a limitation and a restriction that it is predominantly only being delivered out of hospitals. Capacity is a problem. That's the same experience that we're seeing in England and Scotland. So there is a waiting time, and that brings real anxieties that there are people at high risk who may seroconvert before we can get them in to put them onto PrEP. I want to say just a little bit about pros and cons. I've kind of slightly alluded to some of those. I think there are some advantages to PrEP being provided out of sexual health services, but there are also some barriers. So I think if you look at healthcare professionals in general, they're more likely to be PrEP aware or accepting of PrEP in a sexual health setting. And actually some of them, certainly some of the larger services in the UK or in England who were involved in the PROUD study already have some degree of PrEP service provision available, which they're able to link into or scale up. And this probably, well not probably, I think definitely reinforces that disproportionate access to men who have sex with men. It's a double-sided coin. Many of those at higher risk of HIV are going to sexual health services already, but the flip side of that is that it disenfranchises or acts as a barrier to those other risk groups for whom regular sexual health service attendance is not an acceptable thing. And you know, I completely accept that my service and many others is not the best place that a lot of people want to go to. So we need to take our PrEP provision out of the sexual health services. I've mentioned already about the practical limitations there about capacity and consultation time, so I won't say anything more about that. I wanted to make just a small comment about primary care. In the UK, when we talk about primary care, we're kind of talking about general practitioners, general physicians, but also more widely community pharmacies, so things that are delivered outside of hospital settings. I would say that probably certainly in the UK, PrEP is at a zero level amongst primary care physicians. There really is certainly no provision, and I think knowledge is particularly low. But there are opportunities, I think, for us to build on that. It's a challenge because generally sexual health services in primary care are very patchy. There will be some general practitioners that do quite a bit, and then there will be some that do none. And quite often people who come in for relatively simple sexual health or even HIV testing needs get sent up to specialist services, perhaps unnecessarily. There are structural barriers and problems, certainly in the UK, which we've alluded to in other sessions around commissioning and funding. When a pathway, a PrEP pathway, for example, when different components of it are different people's responsibilities in terms of commissioning and paying for it, it makes it very hard to join up service delivery, and that's, I think, a real challenge for us, certainly in the UK. But I think I just wanted to mention we are trying to move forward, and I think we need to move forward. Primary care is a place that we need to take the messages out. One of the things that we're doing locally is developing a PrEP template to sit within the GP's electronic patient record, which I think will be an initial first step in terms of raising awareness, encouraging them to ask the questions and to collect the right information. EMIS is the name of the company that delivers that. It's not the European migrant study that was mentioned earlier. So we were doing some work to move forward with general practitioners. But I do think that greater involvement with primary care is one of the things that we need to do to address the barriers to access. I was musing earlier today and a bit yesterday that for me it feels a little bit like some of the progress that we've made in terms of HIV testing. You know, when we've looked at the fact that we don't test enough, that undiagnosed rates are too high, that we're not maximising the impact of testing in terms of preventing onward transmission, what we've done is we've changed our service model. So we've ramped up testing by taking it out of the sexual health service. We've utilised new technologies like self-testing or self-sampling or online, and I think there are some similar principles we need to apply when we're thinking about models of care for PrEP. I'll skip through this really because I think it just goes without saying, and it came up a lot in the breakout discussions this morning, that frequently funding cost is the single biggest barrier. There are challenges in terms of how services are commissioned. There are ways around that. Scotland has been particularly bold and should be applauded for just going ahead with generics, as in other settings around Europe. But we need to be aware when we're thinking about our service models, how we do that within the limited resources. We should keep shouting for more money, but we should be realistic about what we'll get. And I think there are ways to do more within the limited resources that we have. So just to pull that together, I've got just maybe another 2 or 3 slides, just thinking about how we therefore integrate or better integrate PrEP into healthcare, both in terms of sexual healthcare and general healthcare. It has to start with equity or equality, but equity of knowledge and awareness, of engagement, of access and of uptake. There is no point any of us devising or delivering the most fantastic PrEP service if the people who really need it have not been involved in that development, don't know about it, or for whom it or is not acceptable to them. So that it really involves, and as I said, needs to be the foundation, continued engagement with those organisations who work with those groups who are who have the greatest need for PrEP, but who are not accessing traditional services. And I think the other thing that we need to think about is organisations outside of the sexual health and HIV arena, and we've touched on this before, so people who work with migrants, asylum seekers, mental health, because those people, their primary reason for going for that service may not be their HIV risk, but they have an HIV risk. So integrating PrEP into those models of care, I think, is going to be really important. For sexual health services, I think there are real opportunities, but I think we do need to recognise that there are still barriers to access to sort of traditional sexual health services. We've certainly started to see an evolution of the workforce in terms of delivering PrEP. That's been a sort of a necessity to provide capacity, so many more sort of nurse-delivered PrEP clinics, using healthcare assistants at least to do a lot of the support and the advice around PrEP, if not the prescribing. So those are opportunities for us in terms of developing the workforce and delivering PrEP. We will need to address capacity issues and funding, and I don't think we're talking about that enough. As I said, we're talking a lot about the cost of drug, but we're not really thinking enough about the cost of the wider service provision. If you think about the volumes of the people that we want to get on PrEP who need a minimum of 30 minutes and most often an hour or more consultations 3 times, 4 times a year, it's a huge amount of work that we don't have the capacity to deliver just now. We need to take our sexual health services out of the traditional setting. The Barcelona PrEP point, a great case in point. We need to be setting them up in the community, because for many people, coming to a hospital-based service is not what they need or want. Primary care, I think we have to start the focus. We have to recognise that as healthcare providers, they're way behind the curve. We need to start by raising knowledge, raising awareness, giving them the tools, so things like developing the IT systems that they used to use, so having maybe things where it pops up, have you thought about PrEP, or somewhere they can go within their systems when somebody tells them they're a PrEP user. And certainly other things that we're starting to do in the UK is specific campaigns directed at GPs, particularly those GPs that work in areas of high HIV prevalence. I'm just going to finish off just on the concept of self-management, just because I'm really into self-management as a general concept. Self-management meaning allowing an individual to manage as many of the components of their healthcare as they can. And there's concepts of pure self-management, where you just do it all yourself, or supported self-management, which is led by you but supported by others. And recognizing that PrEP already is a self-managed intervention. People go online, buy their PrEP, take themselves to a clinic for testing, and I think we should build on that. Certainly in the UK, online testing for sexually transmitted infections, HIV self-testing and self-sampling is becoming very much standard of care and norm, and we can build on that. Distance prescribing, telemedicine. So I think if you think about all of that, it is possible to devise a PrEP pathway which could purely be done online, or a mixture of online and face-to-face. And I think that's the thing that we need to think about and evaluate, because it may be more acceptable. It certainly may be more accessible if you don't live anywhere near a clinic that is providing PrEP, and it may be cheaper. You may know there was a presentation at the Durban conference in South Africa from a group in Atlanta about PrEP at home. This is starting to look at this model. This is an integrated model where people come to their physician first and then they go online for their testing. So it's a bit of a mixed model. And we're starting to develop something similar in the UK, but I'm keen to kind of like push that model as far as it will go. So see, can we do it all online? So you could have all of the information, the advice, the signposting, the support to make a decision about PrEP, about dosing. You could deliver HIV and STI tests and renal monitoring tests from a distance, and you could do the prescribing from a distance as well, and also wrap around or link into those other support services that people need around drug and alcohol, chemsex, and so on. Final slide is I think just a reminder for me and for us that we need to keep evaluating what we do. We have a real opportunity as we all start to expand our PrEP programs, and I think we have a responsibility to make sure we evaluate that as much as possible, because there are still a lot of unanswered questions around PrEP. There are unanswered clinical questions, to my mind. I think looking at alternative dosing strategies at the moment, we're very much, on demand, just for men who have sex with men or just for anal sex. I think we need to explore that for other groups. Is it just that you can only have daily if you're in any other group? I think there are unanswered questions about the amount of renal monitoring we need. How often should we be screening for hepatitis C? Who should we test? How do we engage? How do we ensure that the right people are getting onto our programs? And I think as keep coming up, one of the challenges is we look at the demographics of people we're delivering PrEP to. We know that they're not the right mix of risk, but what is the right mix of risk? What should be the relative proportions? And as I said, I think there's some really interesting work that we need to do around service models. What is the best model, where should it be delivered, and by whom? And I'm just going to, I think George briefly mentioned this yesterday, there's some interesting proposals which I think will be really exciting from Scotland, where they're going to actually start to do that work, to evaluate not just the sort of clinical aspects of PrEP delivery, but the models of care as well. So thank you for your attention. Apologies for not showing you my slides. I'm sure they'll be available to you later, and a particular thank you to everybody else who helped me put the talk together. Thanks.
Thank you very much.